When are you going to finish your placement? Few more days?
Say again?
When are you going to finish your placement? Completing your placement?
On this Friday.
Or
In
this
a couple of
Friday?
days. Yes, yes.
Okay. Are you going back to straight away to Australia or you are exploring Kerala?
We've been exploring Kerala while we've been here, but I'm flying out on
I'll leave on Monday, so not long to go now. That's it.
yeah.
Whew. Yeah. Yeah. I've just blanked. Denise joining us as well today. Hello, Denise. Because I saw. How are you? That's good. So.
Okay, so we want to say hello and welcome to Kusumagiri's World Mental Health Day webinar. My name is Ruby, this is Hayley, and this is Denise. And we are all social work students from Australia completing our final fieldwork here in India and within Kusumagiri. We will be running today's webinar presentations. We want to welcome everyone who is accessing the webinar from across the world, and thank you for joining us today to hear from the amazing speakers.
The theme of this year's World Mental Health Day is mental health in humanitarian emergencies. According to the World Health Organization, 1 in 5 people in conflict-affected areas are estimated to have a mental health condition. The World Health Organization also states that these impacts often remain long after physical safety is restored, undermining the recovery and resilience. People with significant mental health conditions must not be left without care and support. Continuity of care is priority during and following any emergency. With horrific circumstances people may have to deal with in complex situations, it is essential that they receive mental health support in order to better cope, recover, and rebuild.
Within today's webinar, the theme of World Mental Health Day and more will be addressed from a range of our speakers. First, I would like to welcome Dr. Sister Jasia to welcome everyone to today's webinar and present some information regarding Kusumagiri Mental Health Hospital. Dr. Jasia belongs to the Religious Congregation of Medical Sisters of St. Joseph. She is currently serving as the head Department of Psychiatry or Psychiatric Social Work at Kusumagiri Mental Health Centre. She has completed her post-graduation MSW in medical and psychiatric social work and secured MPhil degree. She is also working as the coordinator of community outreach and school mental health promotion programs for Kusumagiri. Thank you, sister.
Thank you, Ruby and Haley. Dear esteemed guests, respected speakers, and fellow participants, greetings and blessings from Kusumagiri Mental Health Center, Cochin. Good morning, good afternoon, and good evening, depending on where you are joining from around the whole world. A warm welcome to all participants from different time zones and countries. Special greetings to our friends from Western Sydney University, Australia, and Brainwave Education and Training, UK. I'm delighted to welcome you all to this webinar on World Mental Health Day 2025 from Kusumagiri Institutions, Cochin, Kerala, God's own country. As we gather from different parts of the world, I hope the warmth of Kerala's hospitality reaches you all. Today, we gather to emphasize the importance of the access of mental health services in crisis situations, a theme aptly chosen by the World Federation for Mental Health. As you know, our webinar aims to foster the dialogue, strengthen and collaborate efforts in mental health care and services. We have brought together leading mental health professionals, academic experts, research scholars, and students from different parts of the world to share their experiences and research results in the day-to-day life. I would like to extend a warm welcome to our keynote speaker, Honorable Mr. Justice Muhamed Mustaque, the senior most judge from High Court of Kerala, and our esteemed speakers, Dr. Kuruvilla Thomas from Kusumagiri, Dr. Rosemary from Australia, and Mr. Tomy Sebastian from UK. Dear speakers, your presence and insights are invaluable to this international discussion. I would like to thank our esteemed partners, Ms. Rosemary, Western Sydney University, Ms. Tomy Sebastian, for their support in making this event possible. And I extend a special thanks to our Honorable Justice Mr. Muhamed Mustaque, High Court of Kerala, for his gracious presence and insights on this international conference. Over the next 2 hours, we will engage in thought-provoking discussions on critical topics including India's role model status in mental health care, social work responses to mental health needs in crisis contexts, and mental health social work in the UK. As we begin this meaningful occasion, I would like to invite Reverend Sister Miriam MSA, Administrator, Kusumagiri Mental Health Center, will light up the candle symbolizing the radiance of compassionate love of God Almighty. Sister Miriam, please.
I wish you all the best for all the speakers and all the participants. May God bless you.
Thank you, Sister Miriam. With the light of discernment, wisdom, and knowledge, let us embark on this journey of fostering dialogue and strengthening the collaborative efforts in mental health care and services in order to achieve healing and wholeness in the whole world. I would like to take a moment to introduce you to Kusumagiri Mental Health Center, Cochin. I'll be sharing a brief presentation, only 2 minutes, highlighting our hospital mission, services, and initiatives. Please allow me to walk you through our presentation. Let me share these slides for just a moment. I think, are you able to see the slides?
Yes.
Yes, we can see, Sister Jessica.
With the motto of love serves and God heals, Kusumagiri, one of the pioneering institutions and NABH accredited hospital for mental health care in non-governmental voluntary sector in Kerala, managed by the Congregation of Medical Sisters of St. Joseph. During the early 1990s, our beloved founder, a servant of God, Joseph Pannikaran, realized the real struggle of the poor people to get the medical care and dignified way of living in the society, where he started the first hospital for the marginalized during 1934 in Kerala private sector. These are the different ministries of medical sisters of St. Joseph. They are doing all over the world, not only in Kerala or India. We have general hospitals, mental health care centers, dispensaries, rehabilitation centers, hospice for HIV/AIDS patients, home for aged, de-addiction centers, and center for pain and palliative care, childcare centers, training center for differently able, special schools for children with autism, counseling and guidance centers, and also we have international collaboration with the universities. Our mission is on art of excellence in healing and wholeness. Our mission is focused mainly to provide the highest quality of mental health care with a holistic approach and innovative treatment modalities to achieve healing and wholeness in the lives, to prevent mental illness, to promote mental health, restore and rehabilitate the person with mental illness, focusing on individuals, families, and the society at large. These are the core values we are striving to achieve in our day-to-day life. Specialities of Kusumagiri. We have a patient-friendly atmosphere and open campus here. We have family involvement, active occupation therapy unit, multidisciplinary team, and casualty services for psychiatric emergencies. These are the organizational setup. I am just showing you the slides. This is the multidisciplinary team of Kusumagiri Mental Health Center. Actually, since 1971, Kusumagiri is acknowledged leader in providing world-class mental health services and personalized treatment and care. A passionately committed and enthusiastic multidisciplinary team make this institution a unique experience for the patients and their family. These are the patient management strategy we are focusing. We have the pharmacotherapy, psychosocial interventions, counseling and supportive therapies, social skill training, active care program, and psychoeducation for patients as well as the caretakers. Some services offered at Kusumagiri are, I'm just showing the pictures only, Navajyoti Center for Child Behavioral Sciences. This is exclusively for children and adolescents. This is Autism Training Center. This is the sensory unit of that center. I'm not going to explain everything. Occupational therapy unit for the free movement of the children and recreational activities for the adult patient as well as the children and adolescents. Academic services. Besides that, we are providing academic services for students from different parts of the world, from different disciplines, MBBS, nursing, MSW, clinical psychology, occupation therapy, special education, and also we have international placement and internship. Supervised practice for social work, English training also we started. These are some outreach programs and in-house programs we are providing from our hospital, school and college mental health promotion programs, community outreach, wellness clinic, counseling and guidance centers, awareness campaigns and even celebrations, research and publications, academic initiatives, conferences, seminars and workshops on mental health and well-being for the general public. These are some different units of our campus: occupational therapy, childcare center, rehabilitation unit, lampant adult OT unit, then autism school, special training center for special education. Some pics on our outreach programs. This is our contact details. Okay, thank you all. I just stopped the slide sharing.
Thank you, sister, for that welcome.
Yeah. As we begin this meaningful occasion, I would like to take a moment to introduce to, yes, as a concluding part of my welcome address. Thank you for your attention. I hope you have gained a glimpse into our work at Kusumagiri Mental Health Center. Let us come together to prioritize mental health and well-being and work towards creating a more supportive and inclusive environment for all. I extend a warm welcome to all dignitaries and participants, and let the discussion begin. Now, without further ado, it's my pleasure to hand over the proceeding to our Master of Ceremonies. Over to you, Ms. Ruby G. and Haley Watts. Thank you, and once again, a warm welcome to the webinar.
Thank you, sister.
Thank you. We will now hear from our speakers. If anyone has any comments or questions, please put them in the in the chat section, and there will be time at the end of the webinar for these to be answered. Please keep your audio on mute during the webinar to ensure that there is no disruptions.
I would like to first welcome our honourable speaker today, Justice Muhamed Mustaque, born in 1967, who is a distinguished judge of the Kerala High Court, known for his progressive judgments on family law, women's rights, and privacy. Beginning his legal career in 1989, he has handled nearly 50,000 cases and authored landmark rulings on issues such as cruel, marital rape, and live-in relationships. Beyond the bench, he has spearheaded major legal and social initiatives, including programs for victims, children, tribunal communities, and civic education, and has led pioneering digital transformations in Kerala's judiciary, such as paperless courts, e-filing, and an AI-assisted translation tools. His leadership reflects a deep commitment to justice, accessibility, innovation, and social equity. Justice Mustaque will now present. Thank you.
Thank you, Ruby. Warm good morning to Mr. Tomy, Sebastian. I think you only there deserves more good morning. The rest of good afternoon and good evening. Thank you, Jessie, and thank you, my sister Miriam. It's a wonderful event. I believe Kusumagiri has come forward to have a dialogue. I mean, this dialogue, though I see around 47, 50 persons on the virtual platform, I'm sure that it will reach out to others who are interested in this discussion. I speak to you in two capacities. One, as a judge handling in mental health jurisdiction. Second, I have a role as a legal service committee chairman, which is in a statutory body constituted under the parliamentary enactment. It's called Legal Service Authority Act. Way back 1987, Parliament established Legal Service Authority to do informal justice to the needies and deserving. Initially, it started with the legal aid. Tomorrow, when it's sent out, when I launched a new scheme called Hahen. Hahen means it's in Sanskrit, it's a rising for the mentally retarded and disabled who are totally dependent. It will have its own shape in the future. Well, our courts in India have already declared the mental health is the right to live is it's part of fundamental right. It's part of dignity. That means beyond looking at a person for the treatment, it's a right to live with dignity. Our jurisprudence so emphasize to allow a citizen or any person to lead a dignified life in our country. The court on both judicial side as well as on other side, like through the legal service authority, are bound to protect the dignity of the individual concerned. That is that's most important concern for all of us. Whenever I see the mental health jurisdiction, when I handle it, the problem with the society, they're quite insensitive to the needs of the mental health person. In Kerala story, I happened to hear a story about that in Kerala itself, 16 persons were killed last year of mentally suffering by their own relatives or parents. 16. An NGO based in Alleppey has disclosed it for the reason that they believe nobody would be in a position to take care of them in the future once their life is over and their parents' life is over. That means in 1 year, if 16s were killed, we don't know the past data. Some NGOs will have to collect the past data. It is only because of Kerala, it's a literate state, that disclosure is happening in public forum. But many other states were not. Nobody would disclose what happened to that mentally disabled person. So that it's a scary news for all of us. So what is happening with the society is simple. They feel that these mentally disabled person, mentally retarded person is a burden on the society, a burden on the family. And there is no other way but to get rid of them from their entire world. So this is a big challenge for all of us. Here on, of course, in judicial side, it's such matters very rarely come before us except through a public investigation. Nobody will bring to us to a notice. Police may sometimes take cases on criminal cases against these culprits, but something comes as a consequence of a certain incident or event reported. Now, how to go about to protect this mentally retarded? It's a big challenge. That is the reason I said when I heard this news, 16 were killed in last year itself, in 2024. I prepared a scheme. It's called HAHEN. We are now focusing to give a support system to them. Legal Service Authority is funded by both union government and state government, and they have sufficient support. They can associate with an NGO to give support to these disabled persons, either through legal means or through other providing other measures under the Legal Service Authorities Act. Legal Service Authority works in a different level. From national level, there is a National Legal Service Authority. It's apex authority. The state level, it's called State Legal Service Authority. In Kerala, state of Kerala, I am currently the chairman, being the senior most. And district level, there is another body called District Legal Service Authority. And taluka level, it's at the ground level, it's called Taluka Legal Service Authority. So we engage paralegal volunteers, and paralegal volunteers will be in contact with this the type of persons who require our assistance. So we have a machineries, we have a wherewithal, and we only need to take measures for it. Now, if such a scary news appears in newspaper, nobody could remain in oblivious loop without taking such measures, which require to support such disabled persons. In what way we can do? We don't have an expertise. Maybe hospital, the Kusumagiri and other NGOs, we all work together. We can create a new world for these disabled persons, especially among the marginalized, poor, economically backward family or people who rather instead of giving preference for treatment or giving some sort of rehabilitation, they want to get rid of these mentally disabled persons. So this is a big challenge for all of us. We all need to work together. It is only through collaborative effort we can create some ripples in this movement. The hospital authorities or other authorities, doctors have a limited role in the sense they can't go to and reach out to the people. It is only the system like what we provide, they can reach out to the people. They have their own limitations, doctors and also the health service providers, because they expect the persons who require assistance to reach out to them. That is only possible because of their limited space and time. They have their own constraints. So we need to reach out to these people. That's a big challenge for all of us. Reaching out is the big task for all of us. So at first instance in HAHEN scheme, what I decided is to create a database, which there is already happening through the panchayat or the local authorities, which need to be updated. And we need to, apart from creating a database, we also need to provide a tailor-made measures or customized measures for those needy persons. It may be a rehabilitation, it may require medical assistance, or it may require some sort of other measures to give support to them, economic support or other supports. So we need to have a very holistic approach to the need of mentally retarded persons or disabled persons, and that would be a significant milestone. We all work together to provide such measures to the needy persons. I think dialogue like this definitely would help us to understand the support system which otherwise exists in our country. Apart from Kusumagiri, I don't know many other, maybe there will be some more, but we all need to work together. And I would request sister please be in touch with us. We can work collaboratively and with all. There will be support from our side, and I believe that this today's event would give an opening for us for a hand-holding with you. Thank you, one and all.
Thank you. Sure, as you said, it's a need of the time, no? Need of the hour, I think.
Thank you, Justice. We will now introduce our next speaker, Dr. Kuruvilla Thomas. He is the Chief Psychiatrist at Kusumagiri Mental Health Centre in Cochin, India, and a consultant at Kalamasiri Medical Centre. He is actively involved in global psychiatric leadership, serving as an executive committee member of the Preventative Psychiatry section of the World Psychiatric Association and a member of its Psychiatry Law and Ethics section. He also sits on the Institutional Ethics Committee at Rajagiri College of Social Sciences and is an International Fellow of the American Psychiatric Association. His work reflects a strong commitment to advancing psychiatric practice, ethics, and preventative mental health care worldwide. Dr. Thomas will now present on his topic, Can India be a role model in mental health care?
Thank you for the nice introduction. Warm greetings to all from Kakinad, Cochin. As we all know, we are here today to observe the World Mental Health Day and its theme. I thought that instead of presenting the burden of the disease and the magnitude that it has caused for all of us, we will present whatever services that we have in India and what little we have been able to do so that we can learn more and be able to understand our shortcomings. So with that in my mind, I put the title of my presentation as Can India be the role model for mental health services? We know that the mental health problems, it's very common, but very often it is not properly addressed due to the lack of awareness among people, both relatives and patients. And there are a lot of misconceptions about the etiology of the mental illness, which causes stigma and restrains a patient from seeking help. Added to that, very often we have shortage of professionals and limited access to the services. It's important to note that as early as in the 1940s, the colonial India recognized the need to have a health plan for the country. And with that in mind, the then British government appointed Joseph Bohr, Indian civil service man, to study the problems at that time and to formulate a health plan. Now, he presented his reports in 1946, which is known as the Bohr Committee Report. Now, the Bohr Committee Report forms the basis for all the other developments that we have had and we are having today. So then it was reported about the need to integrate preventive and curative services for all diseases from the grassroots level. And that resulted in the establishment of primary health centers for the public. for at least a primary health center for a population of about 40,000. We know that this was in the late 1940s, and nothing was known about the mental issues at that time. The mental hospitals were actually for protecting the community from the mentally ill people. The first drug to be used in psychiatry was introduced in 1952 only. But later, due to the development of the neurosciences and the social sciences, we increased our knowledge in mental health. And finally, that resulted in the rolling out of the National Mental Health Program of 1982. At that time, 66 to 7% of the population had diagnosis of mental disorder. 1 in 4 in a family had experienced some mental issues. But only 10% of the people were able to get a treatment. So with this in mind, the mental health program was chalked out and the various programs under it came into existence. The objectives of the mental health program are one, accessibility, part of the theme that we have just mentioned. That is, it should be available to everybody, irrespective of who he is. And the integration. It's very important that the mental health system should not be separate, but it should be integrated with the other disciplines of medicines, because we know that health is a physical and mental well-being of a person. And so it has to be integrated. Then we realized that it is not the treatment alone, but due to the development of the social sciences, we know that the community programs are very important. Many of the diseases may not be totally curable, but support from the society is something which is essential. And so the community involvement is very, very important. The implementation of the National Mental Health Program 1982, there are 4 aspects. Number 1, the district mental health program. Then the tertiary care through modernization of psychiatric hospitals and development of the facilities in the teaching hospitals for psychiatry. Then building up centers of excellence like the National Institute of Mental Health Sciences and Neurosciences Bangalore, or the Central Institute of Psychiatry Ranchi, where the psychiatric research, training, and all other developments are being carried out. Also, it is essential that awareness campaigns in the community is absolutely necessary for people to know about the illness and to avail the treatment that is available. Of all these, probably the most important arm of the implementation of DMHP, as far as the service is concerned, is the district mental health program. This is now operational in about 770 districts of this country. It is managed by a team which consists of a psychiatrist who is the nodal officer, a medical officer who need not be a psychiatrist, psychologist, psychiatric nurse, psychiatric social worker, and supported by ASHA workers. ASHA workers means accredited social health activists. These ASHA workers form a very, very important group. They have only a high school level of education, but they are trained to do door-to-door survey, find out the demographics, to see whether any person is sick, and motivate them to come to the hospital. As Honorable Judge said, a collaborative work is something which is absolutely necessary. It is only a teamwork by which can be done. Now, parallel to this, there is again another group in the district mental health program, which is again led by a psychiatrist and other staff who visit centers and give training to even to the primary health center doctors to treat some of the illnesses like depression, anxiety disorders, which they can treat it so that the burden is not there. I'm not calling it as a burden, but because of the lack of the number of professionals, to lessen the work of the psychiatrists. Now, in the particular district that I am working right now, this Ernakulam district, there are 20 centers where the district mental health program team visits every month, a fixed day every month. And people know that this team would be visiting that particular center, the community health center, on that particular day, where a patient can go with the, if he is an already treated patient and is continuing medicines, he can go with a prescription and then see the psychiatrist or the concerned other people. An assessment is done. If the psychiatrist feels the necessity to make any change, is changed, or the same prescription is repeated, and the medicines are given totally free, which is carried from the district center. This is what Honorable Judge meant by saying that you reach out to the people. You reach out to the people, and then only the real service can be given. So the necessary psychosocial support is given, and the ASHA workers, through their door-to-door survey, they may find new patients who are there, who are yet to seek treatment. They are motivated to come to the community health center and see this treatment. This is all funded by the National Health Mission of the center and the state government. Then we have the National Mental Health Policy 2014. For want of time, I am not going to go into the details of it. We have the Mental Health Care Act 2017, which ensures the rights of the mentally ill person when he is admitted. There are procedures to be maintained if a psychiatric patient is admitted in a hospital, to ensure again the ethical rights of admission and to safeguard his safety. These mental health establishments have now been categorized into 5 types. Like, standalone mental health establishments is A, psychiatric department of medical colleges is B, psychiatric wards of multi-speciality hospitals is C, standalone de-addiction centers, centers for psychosocial rehabilitation. Now, this is because the needs of the psychiatric patients are different depending upon the basic problem that they have, and depending upon that, the rules also have to be changed. The attitude of the professionals have to be changed. The medicines may have to be selected in a center depending upon the needs of the people. And so such type of, a specialization in the care is something which we are achieving. One of the important introductions is the Tele Manas app. This was launched in 2024. Manas in Indian language, in Indian language, it means mind. Manas means mind. Now, this app is available. If you are using an Android phone, you can download it from the Google Play Store. If your iPhone is there, you can download it from App Store. And that would give you access to services. There is a national helpline, 14416, which is working 24 hours a day, 7 days a week. Anybody can dial this number anywhere from India at any time and get the service. Now, this is how the home page of this Tele Manas app would look like. It was introduced by the Ministry of Health and Family Welfare. You can see it, like say mental wellness, distress signals, whatever you want, you can click on that and then you get information on that. This is a home page. You can explore, or if you want to talk to the personnel, you click on that. So this is a very, very useful, Tele Manas is a very, very useful app for anybody who is using a smartphone. Anytime they can access the service. So with this type of service in the background, an unexpected event happened, that is the COVID-19. And how did we manage it? Every day, the positive cases were reported. This identification and surveillance center in the state capital, that is the Trivandrum, from the peripheral centers. In the positive cases in the public and the private sector, all were to be reported to this center in Trivandrum. And every day, the state chief minister came on the TV at 16 hours, and the district-wise positive number was given to the public, and the precautions to be taken as per the advice of the medical experts were broadcasted. The telephone lines of these centers were publicized, so people with problems could anytime phone up this center. People with mental problems, mental issues could phone up this center and express their difficulty. Now, this center, again, maintaining confidentiality, depending upon the area from where that they got the telephone call, they would direct it to the nearby district center to contact this person, and it will be from that center the particular person was contacted. Now, the people who are helping this, the first contact was a postgraduate social worker. And if that person could manage the problems, then that would end the matter. But suppose he found it difficult, he would then hand it over to the psychologist. If the psychologist did not handle it, it would be handed over to the psychiatrist. And then the psychiatrist would tackle the problem depending upon what the patient is suffering from. Suppose the person was having psychiatric illness and he was on drugs, and because of the COVID, the pandemic, the lockdown, there were many people who just could not get the drugs. The ASHA workers would be informed about it, and they would carry free medicines from this center to the home of this particular patient. If an admission was required, then steps were taken to send these patients to the district hospital or to the state-run 3 mental hospitals. And unbelievable, there were about 1 lakh telephone calls which were handled. It is about 0.1 million at that time during the COVID. So this was a service that we could render at that time. I've given a glimpse of the services that we have done. We know that probably there are some shortcomings, but then we should know that this is a country with 1.4 billion people. There are many more things to be learned, many more things to be introduced, which I think we would be able to do it with, as Honorable Judge said, a collaborative work and reaching out to the people, going to the people rather than expecting the people to come to us and take the service. That is what we should do. I will conclude my talk by remembering the doyen of medicine, Sir William Osler, who said, the good physician treats the disease and the great physician treats the person who has the disease, thereby implying that the mental health or the person is the most important one. Amartya Sen, the 1998 Economics Nobel Prize winner, he said, healthcare is a fundamental right. It's not a privilege. And so a nation's progress should be measured by the well-being of its citizens. Thank you very much for the patient listening.
Thank you, Dr. Thomas. We would now like to welcome our third speaker, Rosemary Qummoh. She is a mental health social worker with over 20 years' experience. She's currently a lecturer and field education advisor in the School of Social Sciences at Western Sydney University. She focuses her research on the mental health challenges of refugees, particularly refugee women, exploring issues like PTSD, transit migration, and the broader psychological impacts of displacement. Her work uses diverse methodologies to understand how systemic and cultural contexts affect well-being, and she aims to develop effective, context-sensitive mental health interventions. She is also committed to supporting social work practitioners, especially as they work with vulnerable and displaced populations. Rosemary will now present for us. Thank you, Rosemary.
Thanks, Ruby, for that. I'm just going to try to share screen. Oh, okay. Yep. All right. So can everyone see this? Can everyone see my slides?
Yes.
Okay.
Yes. Yes, can see.
Okay, so unfortunately, I can't actually make it like show my screen. Okay, unfortunately, I can't actually, oh, maybe I can. No, it's not letting me. So sorry, it's going to be like a little bit smaller on the screen. But thank you for that, Ruby. And hello, everyone. Just wanted to say it's a real privilege to be here today. I just wanted to extend my gratitude to Sister Josiah for the opportunity to speak with you all this afternoon on such an important topic during Mental Health Week, and especially given the current global crisis of forced displacements that we're actually experiencing. So I'm a little bit that the world is actually witnessing more than we are experiencing. So I'll be talking around one of the themes for Mental Health Week, which is the focus of my research, is around mental health, responses to mental health needs in forced migration and crisis contexts. So I'll look at some social workers' responses to mental health needs in trauma and crisis contexts, looking at these situations which are often complex and emotionally charged, which requires a thoughtful, ethical, and evidence-based approach. I'll look at, and we'll just cover a few of the key interventions, some therapeutic models, and the challenges social workers face in the field. But firstly, I think I can change my slide. How is it that, okay. It's not letting me change my slide. Okay, let's see if that works.
Yeah, it's okay.
Yes, awesome. I have to go back to my PowerPoint to do this. But first, if I can just start off with acknowledging and honor those with lived experiences in mental illness, as their strength and resilience inspires us all. And hearing from our guest speakers this evening, or for me, it's this evening, has just been so inspiring that I think, we need to be able to look at acknowledging, I guess, lived experience with mental illness. So we respectfully acknowledge and honor those who live with mental illness, those who care for loved ones affected by mental illness, and those who carry the strength of lived experience. Your resilience, courage, and advocacy are vital in shaping a more compassionate and inclusive society. We recognize the challenges you face, the stories you carry, and the contributions you make, often quietly and powerfully, to your communities and to the broader conversation around mental health. Your voice matters, your journey is valid, and your presence enriches the path toward understanding, healing, and hope. Okay. So just really briefly, go back to this. Okay, so going back really briefly, I'll be covering, looking at refugees' experiences, and we know that they endure profound psychological trauma as a result of displacement, loss, and instability. Yet mental health care remains one of the most overlooked and underfunded components of humanitarian aid. Prioritizing mental health is not just a clinical necessity, it is a fundamental act of social justice and human dignity. And we heard that earlier from Mr. Mustaque, talking about dignity. I think it's an absolutely valid point. Okay, so really briefly, I'll just give you a quick snapshot of the global displacement. So basically in 2024, on my right, so probably your left, the picture is actually basically talking about the 4 main countries of where people have basically been who have fled from their countries, which is about 122 million people. This was last year's stats. As of this year, it has increased by 1 million. So aligning with the World Health Organization and UNHCR, it is estimated that over 123 million people are forcibly displaced worldwide, facing severe mental health stresses. The impacts that this creates on displaced individuals, where not necessarily everyone will experience, however, Symptoms of PTSD, depression, and anxiety due to compounded trauma and challenges exist. So there is an urgent need for support, and we've heard that from the previous two speakers as well, where there is an urgent need for support around mental health services amid the crisis to support displaced populations effectively. So as I mentioned, I'm talking about the theme and the significance of during emergencies. And what we do know is that it's not optional, it is life-saving. So it enables healing, resilience, and recovery, but it requires coordinated action involving governments, healthcare providers, educators, and community organizations to ensure, to ensure that mental health services are accessible to all, especially the most vulnerable. According to the World Health Organization, 1 in 5 individuals affected by such crisis may develop a mental health condition requiring professional care. So the theme for this year's World Mental Health Day is access to services, mental health in catastrophes and emergencies, which is quite timely. This theme emphasizes the need to prioritize mental health as a key aspect of humanitarian responses and public health strategies during crises. It serves as a global call to action, urging the importance of addressing mental health needs in emergency situations. So some of the challenges that my research has actually shown around displacement is, so they're basically looking at refugees and asylum seekers in Australia. So I can talk a little bit about the Australian context, where we receive numerous numbers of refugees in the country. And basically looking at that. My research actually looks at a three-stage journey, looking at the trauma that refugees actually face pre-migration. So while they're in country, before fleeing, the trauma they actually experience in transit, which I believe is really often overlooked. So this transitory migration stage is often overlooked, and their trauma is more compounded in these transit countries. And then, of course, the post-migration stages, which is in the host countries. Each of these provide the unique stresses which impacts on their mental health. We know that there's a high mental health prevalence, higher rates of PTSD, depression, and anxiety, which affect refugees, with children especially vulnerable to long-term effects than the general host populations. We also know, and we've seen this in a few of the other speakers' presentations as well, is that only a small percentage of refugees will seek professional or informal mental health support despite their needs. So there is low help seeking rates. Some of the psychosocial stresses and vulnerabilities that refugees face is looking at, so upon reaching the host country, they often encounter additional hardships such as inadequate living conditions, social isolation, and uncertainty about their legal status. UNHCR reports that while many refugees demonstrate remarkable resilience, a substantial number require mental health support to rebuild their lives. Integration into national health system remains a challenge. And many refugees with pre-existing conditions like depression, anxiety, or psychosis struggle to navigate unfamiliar healthcare environments. Community-based interventions, including training of refugee volunteers and local health staff, are essential to bridge these gaps. These efforts not only provide immediate support, but also foster social cohesion and mutual aid within refugee communities, contributing to their overall well-being and integration. So a majority of the, issues that we also face here in Australia is the systemic and cultural obstacles. Systemic obstacles that refugees will actually experience. So we go through some key barriers to access, which is the stigma, and we've kind of mentioned that a little bit earlier from my previous speakers. Language difficulties, financial constraints, and cultural differences, which will limit access to mental health care for refugees and migrants. The healthcare system limitations, and we've heard this as well from Dr. Thomas, around underfunded and strained health systems in low and middle income countries, which will hinder adequate mental health support. There's also legal and visa restrictions, which also create a limitation around accessing government-funded mental health programs. There's the stigma and fear around mental health and the fear of immigration consequences, which prevent many from seeking help. There's service delivery challenges where there's this lack of culturally responsive providers and inadequate infrastructure, which worsens the quality and appropriateness of care. The impact of social factors such as educational and gender role influences, mental health care access, with women and children facing added obstacles. Recommendations for improvements that we're basically looking at, and what research shows is multidisciplinary approaches, financial investment, cultural training, and integrated care models can increase equitable access. So some of the strategic actions for mental health equity is looking at, and we've kind of heard this a little bit as well, I think from Dr. Thomas, in terms of looking at some of the actions that we can actually look at in terms of what we need for mental health services, so the investment in mental health. So in order to improve mental health outcomes for refugees and asylum seekers, this is the research in Australia, several strategic actions are to build an inclusive mental health system that empowers and heals vulnerable communities. So we're looking at integrating mental health support, which is embedded in mental health and psychosocial support in emergency and settlement services for effective care. Train frontline workers in psychological first aid to improve immediate mental health care in emergencies. Multi-sectoral coordination, where we establish coordination mechanisms to ensure cohesive mental health and psychosocial support responses in emergencies. Culturally competent care, so expanding the training programs and interpreter services to provide culturally sensitive and mental health care. Community-led initiatives, support and fund community-led mental health programs to empower disabled populations. And finally, policy and sustainable investment, where we look at developing policies to ensure care of continuity and invest in trauma-informed care models for refugees. I'm going to stop there. Actually, no, I'll continue on to this, and then we can talk about international placements, because Sister Josiah basically asked to speak about 2 points, but I'll just quickly talk about some of the social work responses that we do in trauma. Okay, I need to go to the next slide. So I'm kind of cutting across to, I'm not sure why it's not working, but some of the crisis intervention and trauma-informed care that we look at is intervention which will provide the immediate stabilization through rapid assessments and de-escalation to prevent long-term harm. Social workers will look at incorporating a trauma-informed care philosophy where it emphasizes safety, trust, and empowerment to prevent re-traumatization and support healing. Where we've also foster resilience and recovery, where we're looking at creating a respectful environment, fostering resilience and recovery for trauma survivors. Some of the next slide. Support for the strategic and therapeutic approaches, where we're looking at some of the psychosocial support and case management, where you'll find a lot of social workers working in this space, is providing that support that includes group therapy, family counseling, community engagement to rebuild connections and control. Looking at the role of case management, where we coordinates housing, healthcare, legal aid, and employment services for holistic support. Integrated approach benefits, reducing service fragmentation and increase the effectiveness of support systems, and empowerment through guidance. So clients can gain empowerment by navigating challenges with guidance and advocacy. So some of the evidence-based practice therapeutic interventions that we look at using is cognitive behavioral therapy, EMDR for PTSD, and narrative therapy. And I think it's really timely here to speak about coming from, working within a Western perspective. When working with refugees, we look at deconstructing, the Western models or Western approaches of looking at how we approach, the interventions that we use when we're working with refugees and the multicultural communities in Australia. There is no one-size-fits-all approach. And I think it's really important to be able to look at seeing how we can use these interventions from a cultural lens. And I think that's really important. So some of the challenges and resilience in practice that I think social workers actually experiences is looking at that, limited resources. We have heavy caseloads, we've got systemic complexities hindering service deliveries. We look at the emotional toll and client resistance when we're working with traumatized individuals, which can cause significant emotional strain, particularly when there's a lot of mistrust from the clients, which adds difficulty. And this mistrust doesn't come from, from the services or the systems that are put in place to support refugees. It's just their, their experiences from home and transit that they carry over into host. So a lot of the resilience and adaptability that social workers show through their resilience is through creativity, compassion, adapting to change, and peer support networks. And of course, the biggest thing that we do in social work is advocating and a workforce sustainability, being able to look at addressing challenges and advocating for systemic improvements, which is vital to sustain social work and quality care. So this is the last slide. So promoting the way that we look at promoting, resilience and recovery, looking at the social work core, elements of strengths-based approach, where we focus on the client's capabilities over their deficits to foster empowerment and hope. Community support, which is vital for creating a safe that aids recovery. Encouraging autonomy helps individuals regain control and make meaningful life choices. And a collaborative recovery, which is unique. Looking at a collaborative process supported by empathetic social workers. So that's that for the slides in terms of looking at the responses from a social work perspective. I'm just going to go back up to the international placements, which is just here. I know that Ruby, Hayley, and Denise, who's on the other side, the 3 students from Western Sydney University who are currently doing their placement over in India. So I just thought if you'd like just a couple of moments to just share your experiences around the international placement and how that's impacted, I guess, on your, on your social work practices, just really quickly. I know I'm just throwing you all under the bus here.
Yeah, that's okay. So we've had a really insightful experience here on our international placement. Obviously, would never have experienced anything like it back home. Not only the cultural practices, the social work practices, just was a very great experience overall. Do you want to jump in?
Yeah.
My international placements. Okay. It's been a really full-on experience, I think, but a massive learning experience as well, especially, I think, with the topic for World Mental Health Day in terms of being able to talk to and connect with people who are possibly displaced or have experienced extreme trauma, being able to have such a big background of cultural competency after being in India. I feel like it's a massive strength and skill we've all kind of learnt.
It's really opened our minded to be more diverse in our practice.
Yes.
And just very cultural competence.
Yeah.
Yes, it's certainly definitely been an incredible experience. It's such an honor to actually be present with all the patients and hearing their cases, and even all the nurses and psychiatrists and social workers. It's really just been, I guess, a privilege to a degree, because I was not interested in getting into a field of mental health. So this has just certainly opened up my curiosity, and it's been like, okay, when we get back to Australia, let's dig more into it and get the ball rolling with it and find out more about it, and see the comparison with that as well. So I really appreciate it. It's been great. So thank you.
Thank you.
Thank you. Thanks, Ruby, Denise, and Hayley. I know that we just kind of, this was an impromptu kind of like, slide, but I'd like to take this opportunity that, Western Sydney University has worked with Rajagiri for approximately 2 years now, where we've sent students over to do placements in Kerala. And I think that's just been really successful. And just hearing the feedback from all the students, it's just been absolutely phenomenal in terms of looking at the learning, but also what they bring back to Australia. And as I mentioned earlier, working from, Australia being a multicultural community, we work from very different lenses. And, it is about deconstructing the, I guess, Western perspectives, and how do we look at working with that, working within this particular, cultural space, and being able to honor that. So I think it's just been an invaluable experience from what I can hear from the students. And, and we've also got 2 other students that are also in Kerala at the moment. So we've got 5 in total. And just the amazing feedback that we're getting and how it's contributing towards their learning has just been invaluable, I guess, from that perspective. So I really appreciate the opportunity that Rajagiri has been able to provide us to be able to, implement an international placement context. So I want to say thank you for that as well. So Sister Josiah, is there something else you'd like me to cover on international placements?
Yeah, as you said, Rosemary, it is actually we are proud of your students from here now. They are actually actively participating almost all the activities here. They're shadowing with us, and they're doing the other activities with the other staff members, and totally involving with patients and their bystanders, and interacting with others. So definitely, I can say that this placement will do something great for their future endeavors also. They are excellent in communication without the knowledge of Malayalam or any local language, but they are communicating well with the patients and their bystanders. That's a very good observation in my side. And also, they are so committed and passionately involving with all the activities with this. Without any hesitation, they are involving with the patients as well as the bystanders and other staff members. All are telling about very positive comments about these students, especially these 3 or 4 interns. We are proud of them.
Yeah, absolutely. Yeah, that's just absolutely wonderful to hear. So I can see that it's basically been reciprocated. So well done, students, and thank you so much, to all supervisors that have basically been able to take on our students and teach them so much that they're bringing back to Australia. So I'm really looking forward to seeing them all in about 2 weeks' time. They're going to have a well-deserved break when they arrive back in Australia for a week. So I'll be really excited to hear more about, their experiences when they're back in Australia, back in the classroom. I don't know how that's going to feel like. It's going to be really foreign, but it'll be really great to hear that. So again, I really thank you for the opportunity for providing the students.
Thank you, Rosemary, and thank you, sister.
Was that everything for you, Rosemary?
I believe so, yeah.
Okay, thank you. We will now invite Tomy Sebastian, originally from Kerala, India. He lived in the UK since 2002 and holds an MSW from Madras University, a PG diploma in public relations, and a BA honours in specialist practice, children and families from the University of East Anglia. With 32 years of experience in social work and extensive expertise in education training, safeguarding and strategic leadership, he has trained and supported social workers globally, helping them achieve professional registration and career growth. As Managing Director of Brainwave Education, he oversees initiatives in study abroad, training and development, and medical tourism, including unique support for overseas qualified social workers seeking UK registration. Tomy will now present with his topic, Mental Health Social Work in the UK.
Okay, thank you very much. Can you hear me? Yes, can you hear? Okay. I'm really delighted to be here, part of this international webinar. Thank you for inviting me, Sister Jessia, and the whole Kusumagiri mental health team. I was just listening the excellent presentation and different topics by our honorable guest, Justice Mustaque, Dr. Kuruvilla, Rosemary. The presentation by Rosemary exactly resonate with what you have mentioned we are practicing in UK in mental health. Because UK, that is a very welfare country with a warm welcoming migrants, economic migrants, refugees, and people affected in natural calamities and different catastrophes, including Syria, Ukraine, and Afghanistan. So we are getting a lot of these migrants with very severe mental health problems and trauma. So that is the background. So I'm also delighted to mention, before I start my presentation, the pioneering in mental health, the model, the unique model established by Kusumagiri Mental Health Hospital for over 50 years. And I am fortunate to have a partnership for overseas registration of social workers. We are having a partnership between Brainwave Education and Kusumagiri, which is growing from strength to strength in the last few years. So I will be talking about mental health social work practice specifically in the UK. So UK has children's social care, where I worked for 18 years, and I was a team manager in adult social care for 3 years. So total I have 21 years of social work experience in UK. So I'll be talking about some of the practice standards and how we work with the partnership agencies. Thank you for helping me with the slides. Special thank you, Ruby, Denise, and Kylie.
Shall I say?
Okay, yeah. Just we start with how the mental health referral system works in the UK. Anybody can make referrals, including self-referral. For example, if I have a mental health needs, not necessarily crisis, I can go to my family doctor and I can make a referral. That's the first step. Or my relatives and my family members can make a referral. Normally, the referral comes from the family doctors and hospitals, and also the police and the housing department. For example, if you live in a rented house or a housing village, the housing officer, every housing department, there is a housing officer responsible. Any third party, for example, if I see somebody in UK with a mental health problem, and if I'm really worried about their safety and well-being and their presentation, even I can make a referral without their consent. So the law is very, very clear. Safeguarding is everybody's business. That is the model we work in the UK. However, consent for referral is necessary. For example, if it is not a safeguarding matter, we need to tell the patient or client, okay, can I make a referral? Then with their consent only we can make a referral, except it is a mental health crisis and a safeguarding issue. Next slide, please. Okay, so UK is strictly working on mental health regulations and legislations in UK. I heard from Dr. Kuruvilla, India has mental health policy in 2014, because I left India in 2002 to migrate UK as a dependent of my wife. She was recruited to work in NHS as a nurse. So I have still very close partnership and collaboration with agencies like Kusumagiri, but I never studied mental health policy and mental health act 2017 because I qualified in 1990. I studied in Don Bosco, that is one of the pioneer institute in India. So I also heard about Telemanas app. I think India is growing significantly in mental health. However, the Mental Health Act 1983 is the key legislation in UK, which is similar to Mental Health Act 2017. Also, we have Care Act. So it's a mistake there. It is not 2024. Please read it as 2014. That's my mistake. Then, if a person lacks mental capacity to make an informed decision about their care, support, and finance, then there is a process to be followed, mental capacity assessment. That is specifically mentioned in Mental Capacity Act 2005. I'm sure there is a lot of social work students are attending and listening this session. So if you are planning for a career in social work in UK, these are the important legislation you will be implementing as a social worker, either in mental health or in adult social care. Also, we respect equality and diversity. As Rosemary said, Australia is very multicultural. Similarly, UK is also very multicultural. We have practitioners and professionals working from around 175 countries in the UK, including me. There are 125,000 social workers registered with the Social Work England and Social Work Wales, Scotland, and Northern Ireland. So this is a huge professional network. And we also respect and value Human Rights Act 1998. You can Google and find. I sent already a separate big note on mental health social work in the UK to Sister Jessia, together with a copy of my presentation and that big note. You can ask Sister Jessia for a copy for your future reference. Next slide, please.
So,
Any technical problem? You can go.
No.
Next slide.
Can you see the slides?
Yes, we can. Yeah. Okay, thank you. So this is an important, because I mentioned UK mental health service is purely based on legislation. So considering Kusumagiri Hospital, that is not a compulsory admission unit. It is an voluntary admission. But UK also has voluntary admission for treatment, care, and support. But some of the sections in the Mental Health Act 1983 is absolutely spot on. We cannot do against the people's will. The first thing we need to know is a mental health problem. 1 in 4 adults in UK has mental health problems, either anxiety, depression, personality disorder like bipolar disorder, or schizophrenia, the serious mental health problem. 1 in 4 adults, not serious, but anxiety and depression. But anxiety and depression will not be warranted for compulsory admission for assessment. So the law says, Section 2, if I have a mental health problem, and if it is serious in nature, for example, if I am going to harm myself, or I am going to pose a significant risk to others, then Section 2, if assessed by a social worker, a psychiatric social worker and a doctor, a psychiatrist, a person can be detained, even arrested and admitted in a mental health assessment unit, not for treatment, that is Section 2, for 28 days. After 28 days, if the medical board decides, okay, this person has a diagnosis and serious mental health problem, then he can be treated. It is called detention in a mental health hospital. That is under Section 3. That can be up to 6 months. If the continuity of treatment needed more than 6 months, then the case needs to be presented in the tribunal, including court in some cases. So the law is very, very clear. So if you don't know the difference, Section 2 is for assessment admission for 28 days. And if the treatment needed under Section 3, we can detain in a mental health hospitals like Kusumagiri for 6 months. And even there are people remaining in mental health hospital for years. So Section 4, emergency admission for treatment, 72 hours. That we can be admitted in a hospital for 72 hours as per Section 4. Section 5, holding powers. The Section 5, for example, somebody is admitted in a hospital, and if they see that the person is presenting with a mental health problem, the nurses can keep the patient up to 6 hours until a social worker and psychiatrist is seen. So that is the nurses has a power up to 6 hours, and the doctor has a power up to 72 hours to keep in the hospital until a social worker is assessed, so that can be changed to Section 2 or Section 3. Then as per Section 37 of the Mental Health Act 1983, court orders for treatment rather than prison. It's really interesting. The judiciary system is very vigilant in the UK. For example, if somebody make a crime, for example, even a serious crime, killing or somebody harming somebody, and if that person is taken to the court, the judge has the judicial power based on human right violation. Instead of sending that person to a prison, the judge can make an order. This person can be rehabilitated to a mental health hospital under Section 37 of the Mental Health Act, so that people will not be criminalized. If I have a mental health problem, I will not be criminalized, rather than provide that appropriate level of treatment first. Then under Section 41, restricted high-risk patients. The hospital and the multidisciplinary team can apply to the court for a restricted high-risk patients for secure placement, instead of sending them to their own family home, where they will be continued to remain risk to themselves or risk to others. Section 47 makes sure restricted high-risk patients care and support. Section 117 is absolutely important. I tell Sister Jessie, I remember Section 117. I am a big believer, because Kusumagiri Mental Health Hospital is doing Section 117 type of work in a very, very good way for a number of years. For example, if a person is sectioned under 3 for 6 months or more, then that person is discharged from the mental health hospital. That person's care, support, and accommodation is completely the responsibility of the state. It should be provided, and that person must be provided with a care coordinator that can be a mental health social worker or a mental health nurse. And aftercare service is completely free, including accommodation and treatment and care. 117. Sister Jessia and Sister Miriam, your people, the rehabilitation center, number of females and male, they are recovered from their treatment. However, you are providing them free accommodation, continuity of treatment, That is an exact model of Section 117 in the UK. Even your service is even, I will say, even better than UK services 117, because you are providing 24-hour care, including accommodation, safety, well-being, food and accommodation, and ongoing treatment. I would like to congratulate on that note. Then Section 136, police power to remove a person a place of safety. If police found somebody in a street during their official duty, if they see that a person presenting with a mental health problem, and if he's at risk to him, risk to others, the police can immediately arrest that person and admit in a mental health unit for assessment. Police power, 136, that is the section. So you can see how brilliant these sections, with a holistic approach in treatment, care and support, starting from assessment. Next slide, please. Focus of mental health practice in the UK. There are 5 focus. Building professional relationship, which we know in social work terms, rapport building, the treatment plan, care and support plan, assessment, and as Kusumagiri with the speech and language, occupational therapy. There is a lot of professionals working together. So building professional relationship, empowering the people. So I can see people coming to Kusumagiri Mental Health Hospital are free to go around, enjoy the fresh air outside their room, but they are closely monitored and watched. That's a professional relationship. In that journey, I think I'm really impressed. Kusumagiri Mental Health Hospital Social Work Department, headed by Sister Jessie, you are doing absolutely brilliant work. So that is the focus in UK. You are already doing in Kusumagiri. Working through conflict and supporting people to manage their own risk. I have seen you are admitting the patients and there is a nest of kin, husband or wife are staying in your hospital. That is working through conflict. And the accountability and responsibility of the treatment success is based on the bystander. That may be a husband or a wife or a daughter or a son. So you are doing that model also, which is the number 2 model in UK. Knowing and applying legislation. And UK is comparatively better than India. I was really impressed to hear about that app, Telemanas app, which is very, very new to me. I will go and check that up after this session. But mental health act is a huge legislation. But knowing and applying the legislation at the right time, for the right person, for the right reason. We can't simply Section 3 a person just because a social worker. There is a pathway and process to be followed. Number 4, accessing practical support and services. You are doing brilliantly in Kusumagiri. There is a lot of psychologists and psychiatrists, and the continuity of service. I think doctors like Kuruvilla and I have seen Jayaprakash and Sister, your teamwork is absolutely brilliant because you keep your professionals, doctors, even for more than 30 years, accessing practical support and continuity. The same doctor can be seen by the patient. So that is the practice model. Working with other professionals to achieve best outcome for people. I think it is a multidisciplinary approach. End of my slide, I will explain who are the partners in mental health service in UK. So these are the 5 focus. Thank you. Next slide, please. Okay, 5 key areas of practice in mental health. I think it is really important. Enabling citizens to access the statutory social care. Because as per Section 2, it is compulsory. For example, I can stay at home without telling anybody. But if I tell, it's a collective responsibility. Either I can tell my teacher if I'm a student. If I can tell my parents if I am a child. Children under the age of 18 in UK have a separate mental health team called CAMS, Child and Adolescent Mental Health Service. But that service will automatically transfer when the person is 17-year-old to the transition adult mental health team for continuity of care. So that is enabling and promoting recovery. There is no stigma in UK to say that, okay, I have a mental health problem. But in India, there is a stigma involved. I know that. So promoting recovery just based on Section 117 is a classical example. We promote their recovery and their rehabilitation. And intervening and showing professional leadership, especially every person with a mental health problem in UK will have a dedicated and designated key worker. either a mental health support worker or a mental health social worker or a mental health nurse. So that is the professional way of supporting. Then working to co-productively and innovate. There is lot of approaches. Person-centered approach, systemic approach, hospital inpatient treatment model. There is lot of innovative and co-production model in mental health treatment in UK, where social workers are a significant professional. For example, the first assessment for a person before meeting a psychiatrist, the mental health assessment carried out by the mental health social worker. So that is very, very important in UK. Then leading the approved mental health professional, it is called AMP. Either a mental health practitioner who has the power to sign section 2 if agreed by a psychiatrist. So the first assessment should be completed by a person called AMP, AMHP, approved mental health practitioner. So this is the way mental health system works in the UK. So if anybody listening me from psychiatric social work experience and background in India, in Kerala, please, there is an opportunity waiting for you in adult social care, adult mental health in the UK. Don't be shy to apply. Get the registration. Next slide, please. Okay, character assessment, I'm not going to explain. If age of 18 and if they have a care needs, whether it is a mental health needs, learning disability, autism, old age, Care Act 2014 is the key legislation. Okay, so under that legislation, under section 9 of the Care Act, anybody has a care needs must be assessed by a social worker, whether it is mental health, whether it is accident related, whether it is any other issue. Okay, so Care Act is another legislation that will go alongside Mental Health Act. Next slide. I will give some 6 principles of Care Act assessment. I'm not going to explain all this. It is self-explanatory. There are 6 principles. Empowerment. We heard that from the previous slide. Empower the client or patient rather than blaming them, saying that you have a disease or a disability. No, that is not the way. Empower. Prevention. There is a lot of early intervention and prevention services being taking place right from the beginning. We don't want to wait somebody to have a critical situation. We will early intervention and prevention. That is another principle. Proportionality. For example, if a person has a difficulty, we are not going to blame or shame them, but we will say proportionate action. For example, not anybody going to be sectioned under section 3 straight away. No, there are other ways of helping them. But if somebody needs a compulsory admission because of their serious nature, then only we proportionately make the decision by a psychiatric social worker and a psychiatrist. That is proportionality. Protection. Protection for their own life, their own safety, at the same time safety of the family members and safety of other public. So protection is another key principle. And partnership. Social workers are not doing this job alone. It's a combined collective responsibility and accountability. I will tell you in the last slide who are the partners in mental health support. Accountability is another one. The dedicated key worker is accountable. For example, if a person with a mental health problem, if a designated person, the care coordinator can be a psychiatric nurse or a psychiatric support worker or a social worker, it is their responsibility to make sure that person gets the necessary help and support during the treatment and after the rehabilitation until the case is closed. Okay, that's the principle. Thank you very much for listening. The next slide, please. I think my time is getting. Well-being principle under Care Act. It's really important. Why people are coming forward in a country like UK? Okay, I have a problem. I need treatment and help and support. That is the cultural shift needed in Kerala and India, because there is a stigma. People need to be encouraged. Not necessarily when they have a breakdown coming to Kusumagiri. No. Kusumagiri can reach out to communities with this well-being principle as a community project. I had a discussion with Sister Jessie a couple of times. I said that if I am coming back to Kerala permanently, I said I can take in charge of this community well-being project on behalf of Kusumagiri. That is one of my passion. Anyway, that's an offer. Personal dignity, that is the well-being principle. Consider every person he is respect with kindness and care and dignity. That's the first principle in the UK. I think that is everywhere. But India, we don't have that facility. For example, if we go to Mumbai, we can see children in the street. Thousands and millions of children and people without proper home, shelter, and accommodation. I think that is not a very dignified way of working. Physical and mental health support. I think World Mental Health Day, I listened how the legal system works in this country. I was really impressed to listen. The Honorable Judge, Muhamed Mustaque, mentioned about how the judiciary is working effectively and very proactively. I'm really impressed. Protection from abuse and neglect. There is a possibility people with mental health problem will be targeted by sometimes their family members. Oh, I had enough. I have no energy and time to care for them. So the abuse and neglect can be from family members or from relatives. We have seen people are just locked in the room in India, some places. I think social workers and professionals need to reach out to the community to find out how many people are being treated differently because I have a mental health problem. Empower and encourage and educate them to come to a place like Kusumagiri or rehabilitation center that is protect from abuse and neglect. That is another principle we practice in UK. Control by individual. Give them responsibility and treatment and ask them what they want the rest of their life. Section 117. Participation in work, education, and training. And even people's release from prison with a mental health problem, there will be vocational training. When they go back, instead of relapse and coming back to prison or rehabilitation center, there is small businesses and there will be employers willing to give employment. This is another well-being principle. You will be surprised. Social and economic well-being, domestic, family, and personal, suitably living accommodation. For example, if somebody is saying that I can't go back to my parents, I need my own accommodation. Under Section 117, if I have a mental health problem treated under Section 3, I have an eligibility to get free housing from government, free housing. Okay. Then individual's contribution to the society. That's the last one. Okay. Make that person worthy and contribute something back to the, and making a treatment for 6 months. It's a lot of money, but UK, everything is free. Not like we need to pay any penny for treatment. It is completely free. So I don't think India will become in that position nearly very soon. But I think Kusumagiri Hospital are doing some charity work for your patients. I know that you are giving some reductions and even for free treatment. Excellent plan. So this is a well-being principle in UK. Next slide. How many minutes left? Can I have 2 more minutes?
Tomy, I was just about to say that you've run out of time.
Okay. So I'm not explaining, but you will get mental capacity assessment. If somebody has no capacity to consent for their treatment, social worker has to do a mental capacity assessment. Next slide, and the best interest decision. And there are principle of mental capacity assessment which you can read. The social worker has to do that one. Okay, next slide, please. Best interest decision. Somebody has no mental capacity to make a decision to come to hospital. Social worker do the mental capacity assessment, and best interest decision in discussion with the family members, and they will be taken to a hospital like Kusumagiri Hospital. So that is if people lacks capacity. Next slide, please. This is the working partners. I mentioned some of the working partners: family doctors, community or occupational therapists, physio, district nurses, community matron care coordinators, tissue viability nurse, fall prevention team, dementia crisis team, hospice, housing, police, fire and rescue, clinical commissioning group, all under the organization, very important. So the list is endless. So we are all working together to protect and safeguard this vulnerable section of people in the UK. I think that may be end of my slide. Yes. And if you have any more information needed, I gave my email, which is tomy@brainwaveeducation.net, and my UK mobile number with the code +44 77 666 55 697. And I once again congratulate the whole Kusumagiri team under the leadership of Miriam and Sister Jessica. And well done, Ruby and your team, Ruby, Denise, and Haley. And it was a pleasure meeting your head of the department, Rosemary. I never been to Australia. I have my niece in Melbourne. I have a plan to come to. And I had a social work registration for Australia, Rosemary, 2010. I was planning to migrate. I had a job offer also, but by the time my son, who was only 4-year-old that time, now he's 22. He told me other day, Dad, if you want to go and work in Australia, you're most welcome to go so that we can come and meet you there. So I have no plan at this time to come to, but only for a holiday. And wish you all the very best. Thank you for listening me. And I will be having the regular contact with Sister Jessia, one of our social workers from UK, coming for supervised practice at Kusumagiri next week. Okay, thank you very much for inviting me.
Amazing. Thank you so much, Tomy. We are now open for a Q&A session. So if anybody has questions, if you could put them into the chat box, and we will ask our respective speakers the specific questions for them. I believe we do have a question. Rosemary, can you please explain the mental health first aid programs in Europe or possibly Australia? I'm not sure. Probably Australia might be more accurate.
Yep. So this is the mental health.
It said mental health first aid program.
Yes. Okay. So
Yes,
Australia. Yep. Thanks. Oh, yeah. Insert. Yeah. I can hear an echo. Okay. So in Australia, we basically, it's sort of split up into when we're looking at mental health care. It's basically under the accreditation. So for social workers, it's under the Australian Association of Social Work, where we actually have accredited positions such as clinical social workers, mental health social workers. There's a whole list of accreditations. So to work within that particular space, majority of the mental health aspects or the training of mental health will come from a degree. We do also have degrees that specifically more on a master's level around mental health. But there's also a lot, like I believe from Dr. Thomas was talking about, I believe it was ASHWA. So we don't have, for example, high school graduates that would come into the mental health space, but we do have a lot of programs that we can actually look at delivering into the community, such as mental health first aid, mental health. There's a whole range of different mental health training modules that we basically deliver in the community, where they're more like mentors or mentees, as opposed to actual clinical, clinically delivering mental health services. So it's quite widespread. It's nothing specific. There's a whole range of different, depending on the actual community that we work with, in terms of looking at what, if it's from a cultural lens. Majority of our cultural mental health programs and or training comes from organizations that are set up in Australia that specifically work with transcultural, basically looking at multicultural communities. So they develop those particular programs. I hope that it's quite wide and quite, general. So I'm hoping that answers the question for you.
Thank you, Rosemary. If anybody else has any questions, they can put them in the chat and we can ask our speakers if anybody has any other questions.
Is it okay if I just extend a little bit more on that mental health? So I noticed, while we're waiting for more questions. So I noticed, Tomy, you were talking about the UK, the UK model around, mental health delivery, mental health services, very similar to Australia. I think, we've got very similar models. When I was talking a little bit about the accreditation around mental health from our accrediting body, mental health social workers can actually work in medical centers. They can basically open up their own practice. So they do a lot of mental health, specifically mental health services around delivering interventions, more than just the case management. We're actually very clinical. So as a part of what I do at the university, I'm also an accredited mental health social worker in private practice, where I actually see people who are referred by the general practitioners under that model that you were talking a little bit about earlier on, Tomy, where we basically look at, that they're all referred by general practitioners, and we can actually look at delivering services such as CBT, and they're all accredited social workers. So CBT, narrative therapy, or whatever else, basically whichever modality that the actual social worker likes to kind of work in. That's the kind of work that we kind of do. I just want to add that.
No worries. Thank you, Rosemary.
No worries. Did you get any more questions?
I
Then
have no question. I have a comment to make. I am Father Joy James, Jesuit, the director of the counseling center in Cochin. It was started in 52 years ago. Started by the famous Father Kandathil, was in a transaction analysis. But what surprised me that we all talk about it. All three presentations are very good, very informative, very useful. But my surprise is that in Kerala alone, we have more than 3,000 registered social work practices. And we have only attendance also less than 50 people today. Why it's happened? Because everybody needs that mental health is a serious issue in Kerala. Every other person needs to have some either counseling or psychotherapy, but psychiatric help. We all know that. But there is such a is it because that Sister Jessia did not give enough publicity, give to people? I wonder what really happened. Because for me, it's a session like,
Actually, for the week.
Yesterday, I had 2 sessions. One is for the exercise people. I was just talking about mental health. People did not know what's the difference in physical health and mental health. Then evening, I had a talk for the Rajagiri students. There were 200 people online in the evening from 7:30 to 9:30. And this morning, I was also in a law university to talk about the students, the LLB students. Now, what I'm saying is that, very few people have access to this information first. Not to talk about services. Services are available. But not even information we are not able to reach. This is a serious concern for me who are working as a professionals in the mental health area in Kerala, because suicide rate is very high. So many suicides. Every day there is 4 or 5 suicides in Kerala. And today's newspaper has showed that DBR shared that Kollam district has the highest. And in a case of family trouble, that's another major area. We had only 8 family courts. Now we have 36 family courts in Kerala. We have only 14 districts. 36 family courts. I was interacting with one of the chief counselors yesterday, family court. Now this situation is pretty bad in Kerala, though we talk hype about the development and the literacy and all. The low self-esteem is a very serious concern here. People have a lot of knowledge, very little awareness. And the fact that is the people do not know what is the difference between knowledge and awareness. People think that awareness is a deeper knowledge. And I always tell them it is not. Information is not going to change people unless we get insight into life, no? To accept that I have a problem, I have a difficulty, I'm capable of everything, I need help. That concept is not very well surveyed in Kerala. Our education system does not help us to even reflect on ourselves. That's why the critical reflection we only talk about. People do not know what is critical reflection. People think critical reflection is criticizing somebody. That's happened in the political scenario. So, even mental health people are in a terrible criticism in the Kerala. Every doctor is in surveillance. That is the way we are looking at the moment. So we need to have a deeper cultural consciousness, where we have great respect for people and a support system where we will be able to, include anybody, everybody is inclusive, this type of thing. That's my humble suggestion. Thank you for Kusumagiri organizing such a wonderful program.
Thank
What
you.
you're saying is absolutely right, Father. Probably with time it should change. So we have seen the change in the last few years. And this time you see that the mental health, the week mental health celebrations is taken up by the various government departments. So that's a change actually with the people in the government service. Every day there is a program. So all these things should change the people. That is what we should hope for.
thank you, Doctor. We haven't received any other questions, so I think I will conclude the Q&A session if there's no other comments or questions, and I will welcome Denise to do the word of thanks and the closure of the seminar.
Yes. So thank you to everyone for those questions, and for a great discussion, also bringing awareness to Joy James on where is everyone. But now we know this for next year. It's been truly engaging and a meaningful session. As we come to the close of today's World Mental Health Day 2025 webinar, I'd like to take a moment to express our heartfelt gratitude to everyone who made this event possible. A special thank you to our wonderful speakers, Justice Mr. A. Muhamed Mustaque, Dr. Kuruvilla Thomas, Rosemary Qummoh, and Mr. Tomy Sebastian for sharing your valuable time, insights, and experiences with us all. Your words have truly been inspired reflection and hope. Thank you also to Hayley and Ruby for running the session so smoothly, and to Sister Jasia for the warm welcome and thoughtful presentation that set the tone for the day. To everyone who joined us today, whether here or online, thank you for your presence, for your engagement, and your willingness to be part of this important conversation on mental health. A special word of appreciation to Western Sydney University for their collaboration and continued support in promoting mental health, awareness, and well-being. Your partnership has been valuable in making this event a success. And finally, our sincere thanks to Kusumagiri Mental Health Centre team for their dedication, for their hard work behind the scenes and bringing this program together so seamlessly. There are 8 certificates for your participation in today's webinar will be available for download from the website a week from today. As we conclude, let's continue to carry forward the spirit of care, of compassion, and understanding that has guided today's discussions. Let us continue to support one another, speak openly about mental health, and build communities where everyone feels seen and supported. So thank you all once again for being part of this meaningful event. So thank you.
Thank you, Denise, for your wonderful words of thanks. No? I wanted to extend a brief thanks to all of you gathered here. Before that, last but not the least, a big thanks to the wonderful MCs, our dear Ruby and Hayley, and along with Denise, for being an awesome MC and keeping the energy high. Your expertise and smooth handling made today's webinar truly special, truly wonderful. Special thanks to both of you and along with Denise. And I would like to extend my sincere thanks to the distinguished speakers and guests for our inspiring presentations and participation. Your presence has made this webinar a real success. That's very gracious of her. You could acknowledge her effort, that the message like special thanks to Miss Rosemary for accepting our invitation despite your ill health. No, heartfelt thanks because you are ill health and you already mentioned me about that, and I have received a lot of messages from you, but really wonderful. You join us, your presence means a lot to us. Thanks a lot. And I would like to extend my sincere gratitude to our team behind this great success. Thanks for the technical teams, the audiovisual team, and the support staff for ensuring a smooth experience for this webinar. Appreciate the efforts of our coordination team, speakers, and volunteers for making this webinar a big success. Special thanks to Sister Miriam, Sister Christuja, Sister Roina, our team members, Belsi, Elizabeth, Shalini, Rion, and all our sisters and well-wishers. Thank you all again for attending. We look forward to seeing you at our next event. Thank you, Dr. Pula and Mr. Tomy, sir. Thank you all. Thank you, Father James, for your wonderful and thought-provoking reflections on this time. Thank you very much. So let us bye for now. Thank you all. See you in the next event. Bye. Thank you so much. Haley,
Thanks a lot.
Haley can say something regarding the certificate or the webinar documents or anything. we can be available that things too within a few days of time. They can be accessed with our website. I think